The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and thank you for joining in. We're seeing the numbers creep up as people finish whatever they were doing before noon and join us. We're at about 200 attendees right now. I hope that this finds everyone well after a long and hot holiday weekend. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's CHHS CMA Virtual Ground Rounds entitled Transmission, Testing, and Masks, Creating a Culture to Curb COVID-19. Speaking of hot, testing and masks are certainly two hot topics in COVID-19. By now, it's clear that face covering is one of our best weapons to prevent the spread of COVID-19, but many of us still have questions about the best type of face covering in different settings. And like far too many issues in COVID-19, masking has become politicized, and many of us live in communities where people are still not using face coverings sufficiently. Our second topic, testing, is often an area of a great deal of confusion among patients and providers. And like everything in this pandemic, the situation and the science are evolving rapidly. Many of us find ourselves asking a variety of questions. What's the best type of test? When should my patient get tested? How and where can my patients access tests, and who will pay for them? Which brings us to systems issues. I know that many people at the state and local levels are working so hard on this, and by some standards, we're testing a lot, and certainly our test numbers have increased since the spring, but we're still woefully behind many countries in the world on testing. Atul Gawande wrote a recent New Yorker article entitled, "We Can Solve the Coronavirus Test Mess Now, If We Want to." Well, I know that all of us working on the forefront of this pandemic want to, as do our speakers today. So let's see if we can solve these problems right now. Can we move on to the next slide, please? Here's our agenda today. We have some amazing experts who are going to be with us, and they're all here with me right now to say hi. We're going to have a question and answer at the end. But first, for some housekeeping, just a reminder that this is being recorded and will be posted soon on our website, covidroundsca.org, where all previous talks in this series are already posted for your viewing pleasure. We'll move on just to quickly see our speakers' disclosures. And as we look at that, just a reminder that CME is being provided today, so you'll be sent a survey upon the completion of the webinar where you can attest to your attendance. After you complete the survey, we'll send out your certificates, so make sure to complete that survey. Let's go ahead and look at our goals for the webinar. These are our learning objectives, and hopefully we will meet those with this great panel of speakers we have today. And we'll begin with a brief State of the State address by Dr. Erica Pon, our acting California State Public Health Officer, our state epidemiologist, and a deputy director for the California Department of Public Health, the Center of Infectious Diseases. Thank you so much, Dr. Pon, for coming back to join us today.
My mask is stuck, sorry. Great, good afternoon, everyone. Thanks for joining. So I'll try to be brief because we have some really amazing experts on the panel here. I'm really excited actually to see these other presentations. But just, yeah, I wanted to give a quick overview of where we are in California. So this is our epidemic curve as of September 7th. We are at almost 738,000 cases. And what you see here is just sort of the increase in our cases based on their episode date over time. So you can see that we peaked in sort of early to mid-July, and that we have thankfully been seeing a decline since then. And these are sort of the 7-day average is the orange line. And of course, the little valleys there are weekends, because a lot of this is if we don't have good onset dates for people's symptoms, these are based on test dates. But so this is sort of where we are again, and again, thankfully seeing this decline that we hope we will continue. We're not yet, as you can see on this, we're still not down to like where we were at the beginning before we started escalating, sort of at the end of May. And we really are hoping to drive down disease before we do hit flu season, which is coming around the corner. But this is sort of where we are now. Next slide. And then this is looking at statewide, our overall hospitalizations, our intensive care unit patients as well, sort of total beds, and then the ICU beds. So the red line again is the total number of people hospitalized over time. This is based on hospital census data. So this is not the trend of new admissions, but just sort of the beds occupied overall hospitalizations. And then on the lower dotted lines, you can see our total ICU and our COVID positive ICU patients. So those have been fairly steady with a little bit of a bump as we saw our peak in overall hospitalizations, and then kind of in a steady state. And we think we're on the decline here, although we've been having some internal conversations about, we hope that continues to decline versus is it stabilizing again? And we really would like to see that lower. So we're continuing to monitor that. Next slide. And then this is actually looking at deaths, which, as most of you I'm sure know, is somewhat of a lagging indicator. And this again is based on, this is the epidemic curve based on the date of deaths and not the date of report, which I think leads to a lot of confusion. Some of the reports we've gotten, over the last week, for example, still may be from 2 months prior as far as the date of death. But this again shows you one of the first sort of earlier smaller peaks in April to early May. Minor decreases, and then again a peak in sort of later in July, and then some decreases since then. The yellow bar, of course, shows that with reporting lag, that this data in the end here is even less reliable until we see what comes in. But again, definitely seeing a downward trend that we anticipate should continue. Next slide. So, and then just briefly talk about our overall testing task force in California. So we've had a couple iterations. Most recently, we're calling it Testing Task Force 2.0 that just started in the second week of July. And this was right after there was some of the, those peaks that I was just showing you in our epidemic here. The testing had definitely very rapidly increased to consistently over 120,000 a day. We initially had some goals in the state of reaching about 60 to 80,000 a day, and it took a little bit to ramp up to that. I'd say now we're ranging, it's been interesting with the fires and the heat recently in California. We've seen some decreases, especially on the weekends, as low as 80 to 90,000 a day, as high as 130 to 140,000 a day. But overall trends continue to increase, and we're hoping to again increase that. The other important thing is that, and I'll show you later on a brand new testing turnaround time dashboard where we've just developed that we had some challenges with delays in turnaround time, but that has actually greatly improved as well. As far as PCR lab capacity, there's over 400 total high and medium throughput labs in California. There's an estimate that there's about 66,000 tests that can be conducted in an 8-hour period. And the total capacity, if all of these labs ran 24 hours, would be 200,000 tests a day. Some of the challenges that we're seeing with accessing the PCR lab capacity is that, many organizations only contract with just a few major commercial labs, and sometimes there's a mismatch in the capacity and the demand. A lot of these contracts are hardwired. The major labs also may or may not use all the same testing equipment. So some of the, trying to mix and match again, demand and capacity or supplies with labs are complicated by whether or not the interfaces are interchangeable or not. And again, as we all know, the equipment has various national supply issues depending on the time. Sometimes it's reagents, sometimes it's the pipette tips. Early on, as we all remember, there was a swab shortage. And again, trying to make sure the different kinds of labs with the different processes have the right supplies has been a challenge. But that's something we've really, at the state level, tried to understand and try to, again, match the right demand with the right labs and do that as best we can and understand that from the state level. Next slide. So we've continued to try to evolve our testing prioritization guidance. The last one was updated on July 14th. Again, trying to work on at the state level, mixing and matching the labs to improve turnaround time or understanding where those barriers are. And then our team has been meeting regularly with commercial, public, and academic lab directors to address these barriers. Some of the larger labs are subcontracting with smaller labs. Some of the improvements have gone to registration. So early on, many organizations were just still using pen and paper. That of course slowed things down, and then specimens were being held long hours without the appropriate couriers and things like that. So those are just the nitty gritty, you know, devil's always in the details, but working out those details. As far as accessioning, improving electronic registration, adding more RNA extractor machines to different labs has been other efforts of the testing task force. And then again, really working on results transmission. There are multiple transmissions daily and trying to make them every 24 hours minimum. Some of the really large volume labs can do that even more frequently to our electronic lab reporting system, but working on those data issues as well. And then we've been working very closely with Perk and Elmer labs and contracts. So they've been helping do testing, provide testing equipment and supplies for public health labs and safety net hospitals across the state. And they have an open platform equipment that has made that easier. And then you hopefully have seen the announcement we made recently that we are building actually another statewide lab that should basically double our capacity in California for PCR lab testing. So the goal there is that we'll have another 150,000 PCR tests per day that are this new lab that we're building will be capable of. And the goal timeline is to open that in November. The facility is in Valencia, California. And then I'll show you a screenshot next of our new testing turnaround time tracking. Next slide. So this is a dashboard we've created that we are updating periodically. We're still working out some kinks. This that you're seeing is from through the week of August 22nd, and I believe this is posted on September 3rd. So trying to take into account some submission delays as well. But the really good news on this is that the average turnaround time has gone to 1.7 days. We were seeing for a long time, we were stuck at around 5 days. And of course, we'd heard anecdotally about certain labs that had even longer turnaround. And then the percentage of results that are meeting the turnaround time was about 57%, and that's improving every week, so that's encouraging as well. And then the percentage of results meeting turnaround time has gotten closer to 80%. So again, we've made huge progress in the state on this measure as far as turnaround time. And then you can just see the trend over time here on the bottom. Next slide. You know, I think I'm realizing now that I again have seen this really amazing panel, I believe some of our other experts are probably going to talk a lot more about pooling and antigen tests and evolving technology. So I think, you know, again, our testing task force is trying to stay on top of this as well and provide information to, you know, audiences like CMA and our other healthcare partners. But again, I feel like the real experts are later on in this panel. So I think I'm going to actually skip this slide, and the next I'm also conscious of time. This is sort of what we have of note now for these 4 antigen tests as far as their sensitivity, positive % agreement with PCR, and specificity. But again, I believe some of this may be covered later. And we'll be posting this data on our website as well for the testing task force. Next slide. And then I briefly wanted to touch on, which I realize is a whole nother topic, but since the last CMA Grand Rounds that I participated in, we have unveiled this new blueprint for a safer economy with the tiered stages. Next slide. In a nutshell, I won't sort of just read this out loud, but we had been on something that was called a county data monitoring list before this, and it was really the counties were either on or off the list, and we really wanted to come up with a framework that really showed progression over time and showed a way for counties and the public to figure out, you know, where they could see their county going next, and what would be the benchmarks or ways they could progress as far as gradually and safely and slowly reopening various activities or sectors in the state. So we had previously looked at a lot of different indicators, but really wanted to keep it relatively simple, and have been focusing on case rates and test positivity as sort of benchmarks for different tiers to be guiding where a county can be as far as what sectors and activities they can have that are open. We wanted to make this much slower and stricter and more stringent than the first time California reopened. We learned our lesson about opening quickly, and again, so you saw those peaks earlier in the summer. And we really want to keep this as slow, again, balance the economic needs and our just sort of human needs to resume some of our societal and economic activities, but also keep it, again, slow and safe to keep transmission as low as possible as we anticipate flu around the corner. And we also anticipated, knowing that as more and more things will need to be indoors, trying to limit them early on, knowing how much more transmission can be indoors. So again, trying to really moderate the pace at which things are reopening in the state. And also really taking the time, and we're continuing to work on this, more individual and group behavior messaging, which is why the talk today on masking is really helpful as well. Next slide. So this is sort of our overall framework. We picked a color coding. So widespread, or purple, is tier 1. And you can see our benchmarks here about new cases per 100,000 population per day. And we use a 7-day average with a 7-day lag. And then a red tier, substantial disease transmission, moderate, and minimal. And you can see our different cutoffs for new cases per day and testing percent positivity. These adjusted case rates we're using are actually a few things to clarify: that we are just using PCR confirmed cases for these case rates, and they won't include inmate cases in prisons. And then we're adjusting based on testing volume above or below the state average, just to help make sure we're incentivizing increased testing, and as you can do more case finding, not necessarily holding counties back who are doing a lot of case finding. And likewise, making sure that again, having a way to make sure that counties are, if they're not testing enough, to help motivate them to test enough, and it would actually increases their case rate by a measure, and it's a linear adjustment to look at that, so that counties again are incentivized to do a lot of testing and case finding. And then there's a caveat that once they have a low test positivity, less than 3.5%, then that testing adjustment is not relevant for low volume. Next slide. Quickly, I'll just review the rules, and all of this is on a combination of the covid19.ca.gov website, and then there's some other guidance on the blueprint and more about the details of how we're calculating things on our CDPH website on the blueprint for a safer economy. But again, as far as being slow and stringent, every county needs to be in a phase for at least 3 weeks. We had a little bit of a, as we start this, today we're announcing just the 2nd tier assignments. We wanted to again, make sure as things progress, 3 weeks minimum, but some counties who've been already in the purple tier, which is the highest widespread tier, have been there for several weeks already. So after starting, different counties are starting to move through this. Counties can only move forward 1 tier at a time, even if their metrics qualify for further down. I already mentioned the adjusted case rates. If the test positivity and the case rate don't match, we always stick with the stricter tier as far as that goes. So again, we're unveiling the latest tier assignments actually right now on a parallel press conference. And then cities are included, city local health departments are included in the county metrics. Next slide. I think we'll kind of skip through this one as well. We talked a little bit about overall hospitalizations in ICU. And I think that might be the last one. If you can forward to the next slide. Yeah. So, and any other questions about the blueprint? Again, there's a lot of great resources on our website. We continue to update that as we fine tune and refine that framework. And with that, I will, that's the rest of my presentation for now.
Kim, I think you're muted.
Oh, goodness. Thank you very much. Thanks, Dr. Pond, for joining us today, and we'll have you later for questions, which I'm very excited about. The remainder of the webinar will continue with presentations from Dr. Greg Miller. Thank goodness he's here to tell me I'm muted. Dr. Michael Mina and Dr. Monica Gandhi, followed by a Q&A session. This will be followed by a Q&A session, and Dr. Jill Hacker will join us there. Just a reminder as we go along to submit any questions you might have throughout the presentation by using the question box in the control panel, which is located on the right-hand side of your screen. And we'll go over as many of those questions as we can get to at the end of the presentation. So I'd like to turn our time over to Dr. Greg Miller, the Chief Medical Officer of Vituity. Thanks so much.
Yeah, thanks, Kim. And thank you guys for being here. I'm assuming that the audience is bedside clinicians working in ambulatory care settings. So apologies if this presentation doesn't quite meet your needs, but I'm looking at ambulatory docs working in urgent care, primary care settings, emergency departments. So I'm the Chief Medical Officer of Vituity. We see probably 1 out of every 4 to 1 out of every 5 emergency department visits in the state of California. Let me just start out by saying we have come a long way when it comes to testing for COVID. I remember my first patient in early March. He was a young, healthy guy with a sore throat, a very clear COVID exposure outside of the country. He got a sore throat like right after getting out of the plane and came into the ED for testing. And we kept him for like 3 hours waiting for stool. We did blood tests, urine tests, stool tests, and we finally discharged him after he was able to give us a stool test for his sore throat. We sent that off to one of 5 labs at the time in the country that could test for COVID. And then finally, a week later, got results back. And now we're at a state where, many of us, maybe not as many of us as needed, but many of us are able to get results within sometimes 15 to 20 minutes for a COVID test when done appropriately. So with that, we've come a long way. And let me talk about, next slide, please, Ariana. We'll talk about where we are and then also where we're going to go. I want to highlight that we're going to focus on molecular and antigen testing. I'm not going to talk about antibody testing, except to say right now, it is probably not something that should be part of your armamentarium as a practicing bedside clinician if your goal is to diagnose acute COVID. Antibody testing doesn't really play a role, and definitely not nearly as big a role as molecular and antigen testing. And then I'm going to talk a little bit about where we're going to be in the next few months with rapid saliva testing. And then also multiplex testing, which has been big in the news over the past week or so. Next slide, please, Ariana. For PCR testing or molecular testing, viral testing, here's an example of what a PCR machine might look like. Like this is from my hospital lab. This is when you send off your tests from a clinic to a lab, it goes into a machine that looks something like this. The bottom line with PCR testing is you can believe a positive result, but you should be somewhat skeptical of a negative result if you've got a high pretest probability. The sensitivity of these tests ranges, and you see all kinds of numbers. We were talking about this earlier. Probably best guess is 75 to 80% would be a reasonable sensitivity. There are so many factors that go into sensitivity, though. Specificity is close to 100%. So if you've got a positive result from PCR, like that is accurate. That is a true positive, very likely. Whereas if you've got a negative, there's still a chance that that could be a false negative. And that's due to factors such as the collection technique. Was it a great swab, or did somebody just kind of wave the swab in the general direction of your nose? You've got to worry about the particular assay that you're running. Like each test, there are more than 100 different PCR tests out there. Each one has its own different performance characteristics. And then finally, what you have the most impact over is the timing of the sample collection. The highest sensitivity is going to be around when the patient has symptoms, plus or minus a few days. There was a study linked at the bottom there that suggested that if you tested individuals on the day that symptoms begin, you'd have about 2/3 sensitivity, and that would rise a little bit over the next couple of days, peaking around 80% and then slowly decline. I've seen some mathematical models suggesting that maybe it peaks around 90%, and then I've seen some case studies showing that sensitivity is, or a case series showing that sensitivity is more around 65%. So there's a lot of factors, but in general, if you test somebody on the day symptoms began, maybe a day before, maybe a few days after, that's when you're going to have your highest sensitivity. What's interesting is if you test them, weeks after the fact, well beyond the point that they are no longer infectious, you're still going to detect 1/3 of individuals have some evidence of viral infection in their nose. Next slide. One big question that comes out is whether point-of-care testing is available for PCR, and there is availability for point-of-care testing. This is something that theoretically you could be doing in your clinics if you have access to the testing equipment. Here's a picture of what a point-of-care device might look like. This is not actually this is a lab-based piece of equipment, but that's in my own hospital's lab. But you can get something very similar looking to that, about a toaster oven size. The big product that's out there, or the big four, are the Q COVID-19, the Acula SARS-CoV-2, the Cepheid Expert Express, and then the Abbott ID Now. And the reason I mentioned those is just you should be aware as you're doing these tests. If you hear, oh, we got the Abbott result back, if it was the ID Now platform, that's a point-of-care test. And the reason why it's important to understand if you're getting point-of-care test results is that those tests are likely a little bit less accurate than standard PCR testing. The FDA produced an advisory, in particular focused on the Abbott ID Now platform. Certainly some other concerns could apply to the other point of care platforms, saying that maybe these aren't as sensitive as the manufacturer stated. The manufacturer, to be fair to Abbott, the manufacturer did dispute that and say, no, we've got some data that suggests that we're 90% or higher accurate when compared to PCR testing. But I think it's important to be aware that point of care testing is available for PCR tests, but it is likely less accurate than the test that you're sending off to the state labs. Next slide, please. And that transitions us to another type of point of care testing, which is antigen testing. We're all very familiar with antigen testing. This is something we do day in and day out in our clinics with strep, with flu. And the bottom line with antigen testing is you can believe it if it confirms your pretest probability, but otherwise you should really strongly consider doing confirmatory testing, both for false negatives and false positives. The sensitivity, and Erica kind of referenced this in her prior slides, the sensitivity is perhaps 85 to 95% out of PCR, depending on which of the four assays you're using. The specificity theoretically is close to 100%. Although perhaps not. This was the test you read media reports about an Ohio governor who got a rapid COVID test that ended up being a false positive. There are some case studies coming out, I want to say of a summer camp in Vermont or some type of school setting in Vermont where several people had false positives. So the specificity of antigen testing might not be as good as that of PCR. However, despite the fact that antigen testing is not as accurate as PCR testing, that's balanced by a definite increased ease of use that maybe makes it possible for us to do, instead of just one antigen test for an individual, maybe doing sequential antigen testing over a period of days to weeks for individuals, which overall would lead to improved accuracy. This is something that you can be doing in your clinics, and you can theoretically get results back in 15 minutes if you have access to these devices, although they're certainly in short supply right now. Again, I'm listing these tests just because I think it's important for you to be aware of the manufacturers, not out of any commercial interest that, none of us, I think, on this panel have any commercial interest in any of these devices, but it's important for you to know if you hear about the Quiddle, you're talking about an antigen test. If you hear about the Abbott Binax Now, you're talking about an antigen test. And one interesting point about the Binax Now, the rest of these antigen tests require toaster oven sized devices on your countertops. The Binax Now is just a card, and it's been, there were 150 million that are in the process of being purchased and manufactured by the federal government, and they're going to get distributed. So those don't require any additional devices on your countertops. It's just a self-contained card, similar to a urine pregnancy test, like that kind of concept. However, unfortunately, cannot be done at home. They do require a healthcare worker to be involved in the Binax Now. But that might be a test that you start hearing more and more about over the subsequent months as the federal government starts distributing them. Next slide, please. One question that comes up is, when should we not test? I think it's pretty clear when we should test, and that's, anybody, anytime, anywhere, any place. Like, we need to be doing a lot of testing. But there are some scenarios when we should not test. And one of those scenarios would be to do a test of cure. You might remember that when COVID was first, getting a lot of publicity, first emerging, there was a testing pathway, and you needed to test negative a couple times before you went back to work. That pathway has been eliminated just because people will still remain positive on these PCR tests. They are so sensitive for some individuals that even though you're no longer infectious, you still could be expressing virus or particles at least, and have these positive tests, even though they don't mean that you're necessarily infectious. So there is there's actually a recommendation that you do not perform quote unquote test of cures to clear people to go back to work. Another scenario where you would probably not want to test would be immediately after exposure, like on day 0. So somebody with COVID coughs on your patient, or your patient comes into clinic immediately and is like, I just got coughed on by COVID. If you test that individual, that test will not be positive right there, day 1, the same day of exposure. You might want to wait a few days after the exposure for there to be enough viral replication for your test to have the high enough sensitivity to detect it. And then if they do come back negative, let's say you are fortunate enough to have a point of care device in your clinic and you expect them to be positive, but they come back negative, you should probably repeat that test, do a confirmatory test. But the IDSA recommends don't do it immediately. Like, don't do a second test right then and there the same day in your clinic. Maybe wait 24 to 48 hours. if you can get a lower respiratory specimen, but that's probably not feasible in a clinic setting. Next slide. Finally, I want to transition to where we are going in the near future, and one direction we're heading is towards saliva sampling. Saliva is probably about as accurate as nasopharyngeal samples. Nasopharyngeal being the brain biopsy, right, where you shove the swab all the way back in somebody's nose. There are some suggestions that saliva samples are about as accurate as nasopharyngeal testing. Maybe if you do lose some accuracy, you definitely get some benefit in the ease of collection. So patients can self-collect saliva. They can do it at home by themselves. They can do it in their car. They can do it in your office, and you don't have to have a healthcare worker in there getting exposed to an aerosol generating procedure. They can just do it by themselves in the clinic exam room. There's no need for a swab, which eases some of the logistics that have been complicating our COVID testing efforts. And it does open the door to future home-based massive screening programs. I mean, I see a future where my kid would just have a lollipop they would suck on every day before school, and if the stick turns green, he can go to school. If the stick turns red, he stays home. Who knows what this will actually look like. But the ease of collection from saliva, as well as the fact they're reasonably accurate, opens up the door for a lot more home-based screening programs. That said, there are no completely home-based commercial assays currently available. Although that will hopefully change. There are some mail-in saliva tests as well as some mail-in nasopharyngeal tests that are available. You can collect the sample sometimes under video guidance from a clinician, but then you mail it in and get the results back in a few days. But as of yet, no completely home-based assays are available for patients. Next slide. And then the other issue or hot topic that's going to be coming up over the next month or two is going to be multiplex assays. A multiplex assay is a test that is a single swab and tests for multiple things. So you could have like a swab that tests for COVID, flu A, flu B, and maybe RSV if you're looking at a kid. There's a lot of benefit to just doing this with one swab. It really eases the logistics. It makes the testing a lot more quick. If you can do one swab one time and get 4 results rather than having to do 4 swabs over 15 minutes apiece. And it's going to be important for us as clinicians to be making some quick decisions around influenza versus COVID, because that has different implications for treatment, potentially different implications for isolation. Unfortunately, as of now, there aren't any clinic-based multiplex point-of-care assays currently available. Likely some will be coming to market in the near future, in the next few months. There are not in the next few weeks. There are some lab-based assays that are available from the CDC and Public Health. They've published something. And then just today, actually, LabCorp announced that they have a commercial assay. And then last week as well, another supplier announced that they've got a commercially based multiplex assay. But again, that is something that you have to send in to the lab. It's not something you can do, in your clinic, in your countertop. Next slide. This is just a summary slide of everything I just said. It's there if you want it. It'll be posted on the website, as you heard. Next slide. The key points that I'm making here are molecular PCR testing has a reasonable sensitivity, maybe 80-ish%, highest sensitivity around the time of symptom onset. Antigen testing is lower, but it's much easier, not much, but significantly easier to use, and they're hopefully increased availability. Antibody testing is probably something you should not be using in your clinics for the acute diagnosis of COVID. And we're going to see more saliva and point-of-care multiplex testing over the next several months. Next slide. I just want to close by saying to everybody, 6 months ago, I was asking a guy to poop in a cup to test him for SARS-CoV, and now we're able to get these tests within 15 minutes in some cases. So we still have a really, really long way to go with testing and overall with this pandemic, but it's just been inspiring to me to see all of our clinicians pull together under some very stressful circumstances. And so I appreciate everything that you guys are doing for all of our patients, and especially what you're doing for each other. The work that we do is really making a difference, and thank you for your attention and for everything you're doing.
Thank you so much, Dr. Miller, for that presentation. And now we'll continue to learn more about testing, in particular, some new ideas about how to do testing in a broader and bigger way. And we're very excited to have with us Dr. Michael Mina, you can help me out with that. Sorry, Michael, who's who is in the Department of Epidemiology and Immunology and Infectious Diseases at the Harvard School of Public Health and Harvard Medical School. Thanks so much.
Thanks very much. And for context, I'm also one of the heads of molecular virology diagnostics at Brigham and Women's Hospital, and I help in a number of very clinical settings as well. So I'm going to be talking about a different form of testing, and there's a million things that I would love to cover, but this is one small piece of it, and this is how we can start thinking about tests in a different mode and for a different purpose. Next slide. So first of all, I like to show this slide because I think in general in the United States, we've largely become complacent in many parts of the country. But this is to show just how seasonal coronaviruses truly are. And this is a very close neighbor. SARS-CoV-2 is a very close neighbor to the other viruses. And what I'm showing here, especially you can obviously see on the left panel just how the spikes occur with the other seasonal coronaviruses that are known to transmit pretty readily from year to year. And on the right is if you aggregate those over the months. What you can see here is that that this does turn into very, very frequently you'll have October, November, December begins the start of coronavirus season, and it usually will last with different strains through the winter. And so this virus isn't going away. We might be greatly benefiting at this very moment, despite wide transmission that is occurring. We could still be currently benefiting from major disruptions in transmission as a result of seasonality. The biology isn't fully worked out, but if we look at places like Melbourne, which were doing very well at the beginning of this pandemic, are now in full lockdown mode, essentially. So I'd like to show this to say that we should be dealing with this virus with the greatest of urgency, similar to how we would deal with a war. And I think that anyone who's on this call probably preaching to the choir. So next slide. So I like to point out that there's that you just heard a bit about this. So virus testing and serological antibody-based testing, both of these can be done in labs, or both of them can be done at home. Virus testing can be done with swabs, with saliva, all different approaches. Serology generally is going to be blood, but could also be saliva. We do a lot with that as well. And just to be very clear, what I'm going to talk about from more or less after this slide and one additional slide is virus testing. But I do like to point out that from a public health perspective, antibody-based testing can be extraordinarily powerful, primarily because it increases power to detect outbreaks in particular during peacetime surveillance. When you don't know that outbreaks are occurring in a given location, antibody testing can be a very efficient way to monitor for new outbreaks. And in part, that's because the antibodies tend to stick around for so much longer than the virus signal. And next slide. I apologize, I didn't have the slide I was thinking was going to be there. But essentially, the idea is that if you have, if you're doing antibody testing and the signal sticks around for, say, even on the lower limit for a primary infection, like we're seeing with SARS-CoV-2, the first time people are getting infected with a virus, it's usually the case that antibodies will wane, but usually that happens after a couple of months, a few months. And so the signal will stick around for quite a bit longer than the viral signal, which will often turn negative after a number of weeks, maybe a month, potentially 2 months in some small fractions of people. But that means that antibody testing can be powerful for peacetime surveillance. If you know that outbreaks are going on, though, then we have to completely flip into sort of very proactive, not surveillance, but action. And that's the kind of testing that we've generally seen happening as a result of this pandemic. We just heard some of the different technologies and tools, so I won't go into those. I think that there's a lot of caveats and a lot of nuances with each of these tools, whether it be PCR, laboratory-based PCR, open wells, or if it's like the Cepheid and all these closed instruments that are part of the modern microbiology setup. But what I want to talk about now is how we can use these tools to our advantage to really combat the virus in a way that's a little bit unique. And normally when we're thinking about tests, we can get very highly sensitive tests. We can get tests that have very fast turnaround times, or we can get tests that can be performed with very high frequency, in part because they're low cost or they're scalable. Very rarely can you get a very highly sensitive, fast, and low cost, very frequent test. And we're seeing that now. We're seeing that we can't get frequency very high with tests. And so far in this pandemic, we have generally prioritized sensitivity in general over all else, at the expense, for example, of speed to get results. We know that there have been many cases where people are waiting. Across the United States, many people still wait 3, 4, 5, 6 days to get results back from a coronavirus test. After a couple of days, it more or less makes these tests useless, unless you're really doing it for medical purposes with a patient and you're trying to figure out what's wrong with your patient. But from a public health perspective, 3 days is far too long. So this is the usual priority order. And this makes sense because this is how medicine usually works. Cost is rarely considered in medicine, obviously. Speed to get results is very important, but at the same time, if somebody's sitting there with their physician, it's a one-on-one relationship, and the physician can ask the patient to go home and quarantine, for example, until the results come. But if you're trying to do this at a large population, you can't be waiting around and having everyone, every time they get a test done, go in quarantine for 3 or 4 days before the results come in. Next slide. So a fast test that can give results in minutes, that is very, very sensitive, but is very expensive and highly, highly manufactured, like a Cepheid test. They are just not going to be scalable. You can't get them into every household. We can barely get them into every hospital and clinic that needs them. But what about a test that gives very, very fast results and is inexpensive, but that is 1,000 times less sensitive? Most people would say that that's horrible and it's a worthless test. But these tests exist today. I'm holding one right here. If you can see me, this is a paper strip test. I don't have any investments or anything in any of these companies. I just do some of the theory. And a test that's very fast, that's very inexpensive, could be scaled up to huge, huge numbers, but is 1,000 times less sensitive at the molecular level. Is that a useful test? Next slide. So to really get at this question, we have to look at how virus kinetics look inside of a body. And this is too often forgotten when we're talking about laboratory medicine. Usually we think of tests as binary. Is it positive or is it negative? And this is what physicians, this is the information that from the laboratory we give to physicians. We give a positive or negative. Very rarely is it a physician or a public health agency that's getting the CT values or the viral loads from the swab or from the test. So it makes all of us think in binary. But if we actually look at what's happening under the hood during an infection, you have an incubation period, which might be 3, 4, 5, maybe even 8 days sometimes. And during that period of time, it's very questionable whether or not you'll actually detect somebody with positive, as a positive PCR test. But they're probably also not going to be transmitting during the incubation period, and they won't be symptomatic. But once the virus really starts to grow up, it will pass the threshold for PCR positivity, the very, very high sensitivity test. And very quickly, within a day or so, or even less, and in hours to maybe 24 hours, it will pass through many orders of magnitude. And the virus will be increasing exponentially from that period of time. And so even the very low sensitivity test, a test that is 1,000 times lower sensitivity to detect molecules, will turn positive within about a day after a PCR test turns positive. And crucially, it will turn positive approximately when people start to be able to be transmitting virus. And so this is a very important piece, because then mostly when we are evaluating sensitivity of these assays to detect virus, almost always what we are finding is actually this yellow portion here, where we're looking at just detecting viral RNA copies in people long after they've been transmissible and potentially long after they've had any live virus. It's kind of like a forensic scene. The virus leaves a tremendous amount of RNA behind in its wake, and that can be detected on a high sensitivity PCR test, potentially for weeks and many times months. And so by comparing PCR to viral antigen tests, which are designed to really detect live virus, almost all of the loss in sensitivity is really happening after the fact. It's the cases that you're picking up, the swabs that you're getting from people that have viral RNA in them, but don't have any culturable virus. There's no actual live virus there anymore. It's just the crime scene that's left over, and it's like picking up a piece of hair or blood at a crime scene. There's no person anymore. And so this, taking all of this into account, can we actually think of this question slightly differently? Does a 1,000-fold reduction, here I'm just showing 2 lines for 100-fold reduction in sensitivity, but let's say 1,000 or even 10,000-fold reduction, how much does it truly matter if the trade-off is that you can have a much more frequent test? And next slide. And so we've plugged all of this. We essentially build mathematical models. We have multiple modeling frameworks. Some of it is agent-based models. Some of it's SIR type of models for people who do these kinds of things. And underlying these models, we have individual people, and we model their viral kinetics with all the variation and a lot of sampling error and things like that. And this is essentially what we see. When we look at how much infectiousness, if you will, is removed from the population, from individuals, it has much more to do with the frequency from which you can test people over the actual limit of detection of the sensitivity of the test. And so here you can see that if you don't test at all, you'll very rarely remove people. You'll remove some people and their infectiousness from the population because they'll self-isolate if they become symptomatic, for example. But maybe the easier slide to look at, or the easier graph, is on the right side. The total infections. If you don't test and you get 100% of whatever that epidemic might look like, if we test daily or every 3 days, for example, with either the high or the low sensitivity test, we pretty much can we stop outbreaks. We essentially reach herd effect thresholds, and we stop virus from propagating and causing outbreaks. When we start to decrease frequency to maybe testing everyone weekly or testing everyone every 14 days, then we really lose efficacy. And just for context, right now in the United States, we test everyone maybe once every 6 months on average or something. Most people in America have never been tested. So, so we've been putting all this effort into high sensitivity PCR tests when frequency is really what should be the focus. And we just can't get that from a public health perspective. We can't get the frequency of testing with a PCR instrument so great to be able to reasonably do daily or every 3-day testing of a large fraction of the population across the whole of the US. Next slide. And besides just frequency, also the turnaround time. So each of these groups, you have the frequency, and then 0, 1, and 2 essentially reflect the turnaround time. So when we built these models, we didn't even consider that people would be getting turnaround times of more than 2 days. And now we've seen 3, 4, 5, 10-day turnaround times, which essentially makes them useless. But again, as soon as you get to, say, every 3-day testing, if you start to get results with 2-day turnaround times, then that really starts to abrogate the utility of every 3rd-day testing. So the turnaround time also is extremely important here. Next slide. Can't tell. Oh, there we go. And so this is just to give an example. If we have an epidemic that's emerging, the outbreak is really starting to move upwards in the population. And essentially what this is showing, that even if 50% of the population refuses to use the test, and 10% of all the tests that are used fail, and the people who choose to use it and use it correctly use it every 3 days, for example, that alone would be enough to really rapidly turn around the epidemic and be able to contain and control it. Pretty rapidly. Within weeks, we would be able to get epidemics under control. And this is because you'd essentially be causing herd effects and removing transmissions from the population. So it doesn't need to be 100% of people, which also means that they don't have to be perfect. They don't have to be perfect at all. They just need to be able to pull the most transmissible people out of the population at a time when they are still potentially going to go on to transmit to others. So that would be early in their infection. And that's why frequency is just so crucial here. Next slide. So I think this will be my last slide. But essentially, we've been prioritizing sensitivity over all else, and I think that we should really be considering cost and speed to get results as our number 1 and number 2 priorities here. And sensitivity near the limit of detection from a public health perspective should be a distant third, because this is a virus that when it's actually spreading to other people, the sensitivity near the limit of detection, which is around 10 or 100 viral particles, really is insignificant from a transmissibility perspective. To detect transmitters, you just have to detect people when they have, say, 1 million or 10 million viral particles, because people will generally transmit up to 1 trillion viral particles. So we don't have to worry too much of finding people with 100 as an example. So I'll stop there, and hopefully we can answer questions in the Q&A.
Great, thank you so much. We're going to take a turn for a few minutes, and because we thought it was so important that we get both of these topics out to you all really quickly, because they're vital right now. Our final presenter today is going to be Dr. Monica Gandhi, a UCSF professor of medicine and the associate chief in the division of HIV, infectious disease and global medicine, and the director of the UCSF Center for AIDS Research. With that history in HIV and AIDS, Dr. Gandhi has become very, very interested in COVID-19 and really contributed very much to thinking about how we use face coverings in this epidemic. So with that, Dr. Gandhi, Monica, thanks so much.
Okay, thank you. So can you hear me? Okay,
yes,
so I'm going to talk about, okay, great. I'm going to talk about a possible third reason for masking after I talk about the first two reasons for masking, which is around the idea of a viral inoculum and facial masking. So next slide. And sorry, am I control? Okay. So on April 3rd, the CDC recommended cloth face coverings due to the frequency of asymptomatic shedding. So that idea there was that we knew in late February and March that even if you were asymptomatic and felt well, you could shed the virus at high rates from the nose and mouth. So the original messaging was actually to wear a mask to protect others when the CDC put out their guidelines on April 3rd. And really, San Francisco and other cities have realized that we may have mismessaged this in terms of protecting others, and we are going to be updating our guidance here in the city to say that it will protect yourself and others, because there's plenty of evidence from other respiratory illnesses and viral infections that wearing a mask protects you. It's actually why we ask people to wear a mask to protect themselves during influenza season, for example, or have done that with immunocompromised individuals. So it really is this idea that it reduces transmission to you. Next slide. But it is there is really accumulating beyond sort of the known evidence that it reduces transmission in other viral infections. There's accumulating evidence in this viral infection that masking will protect yourself and others. So for example, there was we started universally masking in hospital systems in really mid to late March. And this on the left is a JAMA article, a picture from once we adopted universal masking. Before that, healthcare workers were getting SARS-CoV-2, and then after universal masking was adopted, then healthcare workers stopped getting SARS-CoV-2. And then I think you're familiar with this figure on the right. This was from a indoor hair salons, actually in Missouri, where two hairstylists masked but had COVID and exposed 139 clients. And though they didn't test everyone, 67 of them were negative and the others were asymptomatic and never got symptoms and maybe didn't get it. So we don't know, but it really seemed to protect people completely from that transmission to yourself and others. And really all this evidence on July 14th led the CDC director to say wearing a mask or widespread mask wearing could get this pandemic under control in the United States within 4 to 6 or 8 weeks. We don't have even masking practices across the United States, unfortunately, and we have not had that even despite that warning a month and a half ago. Next slide. So really, when we think about what would help us combat COVID-19, we've talked already in this webinar about decreasing transmission, and masks themselves decrease transmission. But I wanted to turn to another topic, which is also, I think, an important thing about COVID-19 to think about, is that you want to decrease the number of people who get sick. So driving up the rate of asymptomatic infection would also be a good thing, because we are used to thinking of asymptomatic infection as a terrible thing because it spreads virus, but it's a good thing because you don't get sick. So how do we decrease morbidity from this infection? Because unlike Ebola, this is not an infection with a 90% mortality rate. Next slide. So before we talk about ways to drive up the proportion of asymptomatic infection and how masks can help us do that, really just let's remember what is the current rate of asymptomatic infection with COVID-19. And you'd need a really well done study where you mass test everyone and then you follow them from over time, because you want to make sure they're not pre-symptomatic. And that kind of study has been done by people here at UCSF, like Dr. Havlier and Jamie and Marquez, and they did this in the Mission District in San Francisco, where they tested everyone, followed them over time. Lots of other studies have done the same thing, and the CDC has basically given, as of July 10th, a proportion of asymptomatic infection of about 40%. Next slide. So then the question is, what does masking do to that proportion of asymptomatic infection? Well, for a minute, I also want to remind you what masking does. So beyond protecting others, beyond preventing you from getting it, if you wear a really strong mask, it actually, N95 masks do filter out 90-95% of viral particles, which is why we recommend it for aerosol generating procedures with healthcare workers, not for the general public because it's really tight. But all of masks actually filter out a majority of viral particles. So surgical masks, cloth masks, it's why the WHO and CDC recommended those cloth face coverings, because they really do filter out the majority of viral particles. We don't know exactly what percentage of SARS-CoV-2. We know from other viruses, let's say up to 80% of viral particles are filtered out. And it's why we are going to next ask the question in the next couple of slides, well, if you filter almost all of them out, but you still get infected, does that viral inoculum, does that reducing the amount of virus that gets inside your system by wearing a mask, does that decrease the severity of disease? So we'll talk about that next slide, please. So this idea that viral inoculum is related to the severity of disease has actually been around, for a century or more. So there's virologic evidence. This is one of the oldest papers we could find that show that the more virus you get in, the more sick you get, the less virus you get in, the less sick you get. And this has led to a concept in animal models called the LD50, or the lethal dose of the virus, of which 50% of animals die. So meaning we don't want to do that for SARS-CoV-2 in humans, but we do know in many animal models for viral infections what dose makes animals really sick. And there's been animal study after animal study that the more viral inoculum you get in, the more sick you get. So what evidence do we have for that in humans? Because we don't tend to do those kind of experiments with lethal viruses, at least in humans. Next slide does show you an experiment that was done with influenza A. This was a paper that was published in CID in 2015, Clinical Infectious Diseases, where humans were given influenza A at lesser doses or greater doses in preparation for a vaccine trials, wild-type influenza A. And the higher the dose you got of influenza A, the more cough or shortness of breath you'd have, and the less dose you got, the less sick you'd get. And we haven't done this with SARS-CoV-2. We give humans, higher or lower doses of viruses. That wouldn't be ethical. But there was a study out of Clinical Infectious Diseases last month where in a Swiss cohort, there was actually Swiss soldiers, and there were two different cohorts, and one was doing what they were doing sort of very close to each other, and then the other cohort either kept apart from each other 6 feet or masked if they couldn't keep apart. So it was either or, it wasn't actually both. And the rate of severe illness in the young healthy soldiers who were crowded together was 30%, but the rate of severe illness in those who masked or kept 6 feet apart was 0%. So there was no severe illness and no illness in those Switzerland soldiers who kept that distance. And so that's another piece of evidence towards viral inoculum. Next slide. And then this has been shown, next slide, and we'll come back to this, sorry. If you can go to the next one. This has been shown in an animal model with SARS-CoV-2 with hamsters, which is the mask model, which is the model for this disease in an animal model, that the more virus that you gave these hamsters, the more sick they get. And that was the higher dose inoculum is represented by the red lines, and then you can see here really ill and kind of little CT scans, these hamsters, unfortunately, that the higher dose you gave them, the more sick they became. And next slide from here. And then what's the evidence that, okay, well, then would a mask reduce your viral inoculum? Well, again, in a hamster model, when it was simulated for the hamsters to have masking, not only did it decrease transmission, and they didn't put these tiny little masks on the hamsters, but they put them in cages with simulated masking. And those who were in the masked cages, when they piped in the SARS-CoV-2, not only didn't get SARS-CoV-2 as much, but when they got it, they got very mild illness as compared to the hamsters who did not have the masks on. So really is very suggestive that the masks reduce the viral inoculum and that viral inoculum matters with SARS-CoV-2. And then if you could please go back 2 slides, I want to show you one other thing about the influenza pandemic. This one, thank you, which is that there are very suggestive features of this virus and the influenza pandemic that when we were exposed to higher inocula at the beginning of the pandemic, there was more illness. So this is a very interesting study that showed what was trying to figure out, this was in PLOS One in 2010, tried to understand why the second wave of the influenza pandemic in 1918 had a higher mortality rate than the first wave. Usually you have more immunity and you have less mortality in the second wave. And what these authors explained is that it was really during that period of time of the second wave that there was more overcrowding, more exposure of people to each other during World War I with overcrowding of soldiers and so on. And so it really led to possibly that higher viral inocula leading to higher mortality. And we saw that in a way with SARS-CoV-2. Healthcare workers, unfortunately, were much more likely to get sick before we started universally masking. Healthcare workers in places before masking died of SARS-CoV-2. We haven't seen that in the setting of masking. And then the really sort of tragedies that happened in Italy and New York City, for example, before masking was ever part of our equation with COVID-19. And then household contacts being more likely to get sick from someone who's shedding than someone who's outside of that place. So then forward 3 slides. So thank you. Perfect. And then what would be the mechanism by which higher viral inocula leads to more severe disease? To put it simply, with viruses where the viral pathogenesis really depends on your immune system, where it is essentially your immune system plays a role in how sick you get, so-called immunopathology, you really can't handle the load of a high viral inocula. And that leads to a very disorganized innate immune response with lots of cytokines and lots of crazy trying to control the infection, which leads to more severe disease. It's probably one of the reasons why dexamethasone is really the only treatment for COVID-19 that's been shown to have a strong mortality effect, as opposed to when you have a lower viral inocula, you're really able to, in a more organized way, control the infection from spreading. So next slide. Okay, so if I have convinced you that it's known from virology and long-standing studies in viral pathogenesis that the higher viral inocula leads to less severe disease, and then if I've convinced you that masking reduces the viral inocula, have we seen in epidemiology or in outbreak investigations that masking drives up that proportion of asymptomatic infection? And this is an example of the tale of 2 cruise ships, but at the beginning of the pandemic, when we had cruise ship outbreaks, that's kind of a closed environment. In a way, it's an experimental environment because, again, we can't really randomize communities to not masking. I think there's too much evidence for masking at this point. But in the Diamond Princess outbreak, one of the earliest outbreaks, the rate of asymptomatic infection was 18%. And then this was another outbreak. This was actually going around Argentina, and this was published in BMG Thorax. And in this particular outbreak, everyone was given masks on board. So after COVID-19 was detected, the passengers were given surgical masks. The staff were actually given N95 masks as they were delivering food and helping with the passengers. And the rate of asymptomatic infection in that case was 81%, so much higher. And then there have been other examples of this in the food processing plant industry. there was a lot of illness and infections early on, then many food processing plants went to universal masking and actually mandating and handing out masks. And in recent outbreaks in food processing plants, like a Tyson chicken food outbreak, and also up in Oregon at a seafood processing plant with universal masking, the rate of asymptomatic infection was 95%, so much higher rates when universal masking is adopted. Next slide. And then this was just from the MMWR last week, but healthcare workers also is another example where we have been universally masking in the hospital. I think Boston went to that on March 25th. We followed suit the next day. And in that setting of universal masking, there actually has been quite a few undetected infections in frontline healthcare workers, but they were all asymptomatic. And most likely in the setting of masking, we have a lot of less severe illness that maybe go undetected. Next slide. So, and then the final piece of evidence is really what's called ecologic evidence, which is country level evidence. It does seem true that countries that have universally masked have seen lower case fatality, or at least lower rates of severe illness, even though they are not testing actually a lot of people with asymptomatic infection. That would actually artificially make it seem like it's even more of a deadly virus. But even in the setting of not having a lot of asymptomatic diagnoses, there's been a lower case fatality rate. So these are countries like Hong Kong, Singapore, Vietnam, Thailand, South Korea, that even when they open up, you'll see cases, but not that severe illness. And the Czech Republic is an interesting example just because it wasn't used to masking like these other Asian countries were with the 2003 SARS pandemic, but this country mandated on March 23rd that everyone universally mask, and they've had very low death rates. And in fact, every time they'd open, they'd see these cases, but they'd see a lot of asymptomatic disease and not the rates of death and severe illness. And as of May 11th, they told their population they could relax the face masking. So a good example of a country that sort of took it on, not been used to it before. Next slide. And this is a model that shows that even after lockdown stops, if you don't continue masks, that you're going to see more of those deaths. That's the gray line. But this model simulates that with 80% masking in a population, you can keep the death rate flat. And with 50% masking, it will still be a little higher. So it really is the higher compliance, the better. Lockdown obviously is a very blunt instrument. And on the other hand, masking takes behavior change. And it does take convincing and not just for the public good, but for your own health. And I think that's why it's important to message that. And that's why we've changed the rules here in San Francisco to be able to message that to people with all this evidence. Next slide. And how about in San Francisco? I think this is a place that you could fairly say tests a lot and has relatively good compliance with masking. Hard to tell. It's dependent on community. We're not handing out masks at every workplace. There have been many Asian countries that have suggested that is helpful for mask compliance is the actual handing of masks, which we do in the hospital setting. But we have a lot of asymptomatic infections here in San Francisco. We have a lot of testing, and just even dating since June 27th, where we started seeing increase in cases, even though we've had more than 6,000 new cases, we've had very few increased deaths since that time. So our case fatality rate is very low. Does masking have something to do with it? I think it's one of the reasons. Our hospitals have never been flooded as well. And then of course we have better treatment. So I think there's lots of reasons, but I do think masking is one of them. Next slide. And then my final point that I'll leave you with is a maybe tantalizing moment is, can driving up the rate of asymptomatic infection drive up immunity? It is true that just to put it simply, right, there's two arms of the immune system, the B cells and the T cells, and the B cells is what leads to production of antibodies, and the public has gotten the idea that antibodies mean immunity, but of course that's just one arm of the immune system, and it's really cell-mediated immunity, how we think of as the main arm that fights viral infections, and the memory T, and then even B cells and T cells can go into memory T cells and B cells and be stimulated. And so next slide, do we have any good evidence that with asymptomatic or mild infection, we're getting T cell immunity? Yeah, there's been some really nice articles over just the last month that have gotten quite a bit of attention in Nature and Cell and Cell Reports Medicine that looks like even with really asymptomatic infection, you can get really strong T cell responses to SARS-CoV-2. We certainly have seen some nice antibody study from the Iceland study in the New England Journal last week, even if antibodies do wane with some of our antibody tests, depends on the test. And then the fact that we've had so few reinfections when we're at 28 million cases worldwide and counting, and that's, really under testing, leads us really to the fact that, like other coronaviruses, there is immunity with the coronavirus. And so that led us to write an article, next slide, that came out in the New England Journal today about the possibility of facial masking doing lots of things. It decreases transmission, it decreases severity of illness, and if you get an asymptomatic infection, could it also even help you get immunity? We call it a potential for variolation as we wait a vaccine, because having mild infection and getting immunity is a great way to also increase population level immunity, which will in and of itself decrease the spread of the virus. So it's a theory, it's a hypothesis, but I think masking has multiple uses for pandemic control. So I'll end there with the final slide with the key points, which is, I think we've gone all over these. Masking may have more than one advantage, and this is a picture of a cat that was masking along with their family in 1918, and then I'll leave you with the key points on the last slide.
Thank you so much. Thanks so much, Monica. We have had such great presentations. We are now going to move on to the questions from our audience, and unfortunately, because of the volume of questions, we won't be able to get to all of them. Joining us, though, for the questions, I'd like to introduce Dr. Jill Hacker, who is the Section Chief of the Vaccine Preventable Diseases Section at the California Department of Public Health Viral and Rickettsial Disease Laboratory, and she'll be joining us right now. I would like to start with some questions that came in for Dr. Gandhi. First of all, people are really curious about what type of masks the public should be using, because there's been a lot about, these buffs, are they not working? Are bandanas not working? And is any old cloth mask good? How do we tell if it's good? In France, I hear that they're not recommending the ones with the seam down the middle. Does that matter?
So I actually think that most and all masks work as long as they cover the nose and mouth. The authors of the article in Science that was looking at transmission out of masks and neck gaiters and bandanas actually issued a letter that said, please don't misunderstand us, that we didn't mean to imply that anything that doesn't cover the mouth and nose doesn't protect you. So I think there was a lot of kind of hype around that they don't work. Really, we don't have great studies, of course, in humans where they've piped through SARS-CoV-2 while humans are, wearing different masks, because that just wouldn't be ethical. So from other studies, from other respiratory viruses, from what we know of sizes, it just looks like any cloth mask that both covers your nose and mouth protects you. And so, but this is the key. It has to cover the nose as well as the mouth. It really has to be snug so that you're comfortable. And it does look like 2-ply is better than 1-ply. So the surgical masks are actually 3-ply, but 2-ply is just fine. And those are those routine, good-looking facial masks. Make them, because we're actually asking someone to mask, like totally change our behavior, I would stress comfort. I really would stress comfort and whatever works for you and kind of like you like and feels comfortable to you. Would definitely not recommend N95 masks for the public. It's not just a matter of saving PPE for healthcare workers, which is important in this case. They're terribly uncomfortable and it's not necessary. And in fact, that's a way to decrease acceptability. So please, I would just not recommend those.
Great. And then I'd like to ask one more masking question, because a bunch have come in really about sort of how do we get to that behavior change? How do we convince patients who are not wearing masks and all of us who really want to take our masks off when we're with friends and family? Dr. Gandhi, I know you've done a lot about behavior change and kind of adherence in your HIV work. If you have any tips about that. And then Dr. Pond, we'd love to hear from you what the state is now doing. You alluded to the fact that maybe there are some more communications campaigns, and what's the state doing to help think about behavior change broadly in use of face coverings?
I'd love to hear Erica's, yeah. Maybe I would just say one thing about behavior change, because I'd love to hear what the state's going to do. I would say that the one thing about behavior change with masking is it really is temporary. We're not asking people to mask for the rest of their lives. And so I think that it's really different than adherence to antiretroviral therapy that I have looked at a lot, or condoms for HIV prevention, which is kind of a lifelong thing. I think in this case, you could think more about mandates and kind of what San Francisco has done, which is put out mandate after mandate, and I think it's helped us. We have three reiterations of the mandates, really kind of more strongly worded each time, and I think it's helpful. And remember, we're not asking for a lifetime, but I'd love to hear Erica's thoughts on the state.
Sure. I think what I was talking about earlier was a combination of things, but I think also really trying to do more targeted sort of strategic campaigns. So there's a great one that just came out with COVID and the Rona, really trying to look at, I think the Rona was really great as far as young kind of college age, which is clearly the latest concern and topic du jour, just really trying to be this sort of silent character with the virus and like approaching and seeing like all these opportunities to spread disease. So those were just launched in the last couple of weeks, I think continuing to reiterate. And then as far as masking specifically, so we have had this statewide face covering order. And then I think really adding this layer that Monica was emphasizing that, you know, for the longest time, I think at the state level as well, we were really talking about your mask protects me and mine protects you, but really emphasizing, and we just started to do this actually on last week's Zoom with Secretary Ghaly and myself to talk about actually the mask is protecting you and each other. I love this idea. I can't wait to see your New England Journal editorial about really thinking about it as sort of a like a vaccination. I think I will just be frank. I think it's so interesting how divisive the mask issue has become. And so to everyone, you know, I think some of this has been alluded to. It is a behavioral change. It is something that people need to adapt to. And I agree with Monica. It's not asking people to do it forever, which is different than some of the other behavior changes, but it is a long time, especially in sort of, you know, the average American and certainly a young person's sort of immediate radar. And I think But so trying to really manage, and when we were launching this sort of reopening framework too, trying to really continue to manage people's expectations that we are asking people to do this for several months, right? At least a year, probably. It just depends where we're going to get with other things. I also really loved seeing, though I hadn't actually seen Monica's talk yet. I've heard lots of great things about it, but this idea too that that you might actually have mild infection and increase some immunity in the population around that. I think that's definitely something to really message more, and that is something we haven't done yet. So we'll definitely be thinking more about that. And again, I think as a start, a very basic start, just making sure that message is out there, that it's protecting you as well as others. I think, again, the challenge is getting community leaders on this, amongst the ones that are not embracing this right now, to actually figure out how to get them to embrace this. Because I think what I'm seeing statewide is very different than when I had sort of more of a Bay Area lens. And it's still a very divisive issue, as illustrated by, if any of you've seen the pictures from the Capitol protest this weekend. There were 12,000 people, none of them wearing masks, including some of our elected officials. So I think we have a large, we have a challenge ahead of us as far as behavior changes, and would love other people's ideas and love some of the great science that Monica's brought to this that will help us try to do that behavioral norm. And I think, as we all also know, everyone on this panel and many on the call, I'm sure, are, you know, we're just learning so much in medicine and public health about it's not the science sometimes that gets people, and how do we also do other behavioral changes. So I think that's where we really have a huge challenge, that we will need community-wide participation to really shift the needle on mask wearing and behavioral change.
I want to just add one more thing beyond modeling mask wearing, which I so agree with you, Erica. Like, I don't think there's ever been a country where masks are announced without the modeling of it. The second point is that handing out masks in essential workplaces, I think, can be really motivational, because it's like saying that is a norm of your workplace. Like, I can't even go into my workplace with my cloth mask. I'm told to take it off, and they give me my mask because it's been modeled because I work at a hospital. So, so handing out masks when available.
Great, thank
and
you very much.
And that is happening.
Oh, good.
Sorry, just
I'm
quickly
gonna
about requiring employers more and more to do that. Yeah.
Great, thank you. I hate to cut you off. I'm sorry. We have very little time and so many great people here. So I want to ask a couple more questions, and I'm going to pivot to testing to do that. Just for a quick clarification for those of us who went to medical school a really long time ago, Greg, if you want to just tell us the difference between a PCR and an antigen test in a super quick, just definitional.
Yeah, definitely. PCR tests for the viral RNA that's present, antigen tests for the protein that is present on the virus. So both tests for the virus. PCR is more complicated and more costly. Antigen tests is easier to do and can be done like in a cartridge, like a urine pregnancy test.
Great, thank you. That's just what we needed. And Dr. Mina, I'm going to ask you the $1 million question. I'm sure you've been asked it a million times, but you're really focusing on this effort at cost and speed, increasing the frequency of testing. So two-part question. One is, how are we going to get to rapid testing at scale? And are we going to? How are we going to? And when are we going to? And then the second bit of the question is, as we're doing that, presumably it'll be a stepwise process. We won't have as many tests to test everyone at the beginning. So who would you prioritize as kind of the most transmissible or the most important places? For me, I'm thinking schools, teachers, maybe institutional settings. So comment on those two things, please.
So I think if the tests come about and are available with some volume, then the first places we want to put them aren't necessarily, I think we first need to focus on where we can put them where cases are still burning through populations. And so that would be the first thing. So we don't need tomorrow to come out with 330 million new tests a day. But we might, if we had, say, 5 million of these tests every day being produced, which is completely not unreasonable. And probably we can do quite a bit more if the federal government coordinated around it. We would first put them into cities and locations where cases are emerging and cases are really still out of control. And then within that, we would probably try to find, doesn't need to be everyone again within, because again, these aren't, I wouldn't recommend that they be used first and foremost as passports into events. That's not the way that I look at these. I look at these much more in the same vein that we look at vaccines. And so that's, again, because we can elicit herd effects through severing transmission chains. So in that regard, we want to look for not necessarily who are going to be the most vulnerable people, for example, but potentially who is most likely to spread to the most number of additional people. So that actually might be schools, might be business, might be essential employees that have to go and work amongst other individuals. And those would be the kinds of places that we want to focus on. The good thing is these tests, if they can be performed at home, then they can actually be used very different than all, because they don't have all the logistics surrounding them, PCR, they can be adaptable. And they can be moved to, somebody could get a pack of 30 of them, for example, and use them when they are at risk of transmitting to others. So it doesn't even have to be every single person every single day. If somebody's, or those who are participating, it doesn't have to be every day or every 3 days. If you're not leaving your house for 10 days, then just save the test. Don't bother using them then. So I think that we should really be looking first and foremost at where are the cases occurring, and then who is most likely to transmit.
All right, and if you had to put your money on it, when are we going to get rapid testing at scale, or are we?
We could have had it months ago. We're seeing that these are easy tests to produce. I held one up before, I think, but this is a rapid test here. These are super simple to produce. It's a technology that's been around for a very long time. Abbott came out with their Binax Now assay, which has a claim for symptomatic people in the first week of infection. Essentially, it's when they're most optimal. I would suggest that is essentially the same test as one of these. It's just a little bit more packaged and manufactured to be a diagnostic, medical diagnostic. So they can be available. The same factories that make them in China, essentially a lot of these are produced in China. They could be producing them right now for the United States and for the world. They are producing them. Actually, it's just that the US isn't really participating too much in acquiring them from abroad. 3M, for example, if they turn on their manufacturing lines for these, 3M has been working with MIT to produce them. We could potentially have millions a day from one company. And so I think my feeling is that the FDA and others, there's been a lot of regulatory hurdles because we have no lens in this country besides medical to evaluate a test. And so this, I would say, is a public health test, needs a different pathway, but we don't have that. So that FDA regulation has been a big hurdle. But certainly we've been having many more conversations with them and with the administration and others. And so I think we're going to continue seeing sort of rapid fire introduction of a number of these different tests in the next month or two.
And so in a final word, either a yes or no, because I want to get to one final question for Dr. Hacker, is this mostly a regulatory issue that we haven't gotten to this yet?
I think equal regulatory and manufacturing.
Yes or no? Okay, good. Thank you. And Dr. Hacker, I just wonder what your view is on, it sounds like the people at the state labs have been working incredibly hard to broaden testing and increase it. Maybe you can just talk to us about, as you think about evolving lab testing in our state, what are you most excited about being able to do in the months ahead? Oh, you're muted. You're muted. No, not yet. Oh, so frustrating. Technology. All right, maybe we won't do that. Dr. Pond, maybe you can jump in and answer whether you, oh, there you are, you're on.
Sorry. Sorry about that. Yeah, so what are we most excited about? What we'd really like to see is an easy rapid test, but that for which we could also get the results reported to public health. I think the idea of these rapid at-home tests is fabulous, but how do we get the results on a population base or person by person to public health so that we can use the data to respond? That's one of the questions that I really am quite interested to learn how we can do that. And, you know, most people have a smartphone. I would like to think that we could use smartphones. Somebody takes a test and somehow transmits that information securely so that the data can be used. I think that an easy to collect sample like saliva or something like that, and something where it's, you know, capillary action, you get a quick result. That's the way to go.
Great. And Dr. Pond, is that something that the sort of private tech world should be doing, or is that something that can be coordinated by the state in like 2 words?
I think both. I think we need some collaboration, and we certainly have that on our task force. And yeah, just trying to think about how to fit it all together, complement and be strategic about all this testing.
Great. Well, unfortunately, that's all the time we have for questions. I just really want to thank this amazing panel for presenting today's content, and thank everyone listening in for taking the time to listen. I apologize we weren't able to answer so many questions that you asked, but we do have a mechanism by which we're trying to answer many of the extra questions through some toolkits and FAQs online. So keep going to our website for that. And by the end of the day, just a reminder, we set that survey where you can attest to attendance and get your CME things, and then you'll also get instructions on how to access the recording of the webinar if you want to forward on to anyone. And we are grateful for you all. We will see you next month, and the next session will take place on October 13th, and we'll be discussing updates in therapeutics. So registration can already be accessed on our website. Thanks everyone, and have a great day.
Thank you.
Thank you.